If you can mask ventilate a patient, intubation becomes a luxury rather than a necessity. In anesthesia, we consider mask ventilation much more valuable than intubation. This video covers how anesthesia mask ventilates and some essential parts of our anesthesia gas machine. Anesthesia calls standard pre-hospital technique the triple airway maneuver. One person applies the mask with both hands, while another squeezes the bag. We reserve this technique for difficult airways. The triple airway maneuver slows OR flow by taking people away from other duties and increases cost. In our controlled environment, most airways do not need two hands. Plan on controlling the mask with one hand while with us. With proper technique, over 99% of airways can be managed with one hand on the mask and the other on the bag. We expect you to use this technique while with us. That said, mask ventilation with one hand is less forgiving and requires perfect technique. What you learn using one hand will greatly improve your success when using two hands in the field. This picture demonstrates classic one-hand position. The thumb and second finger secure the mask with gentle to moderate pressure. The third to fifth fingers lift the mandible upward and into the mask. The fourth and fifth fingers are at the angle of the jaw and thrusted upward. Note that all the fingers stay off the soft tissue. Wrapping fingers around and into soft tissue closes the airway. This side view exaggerates the importance of thrusting the jaw forward. Both the fourth and fifth fingers combine pressure at the angle of the jaw. The third finger controls head movement and applies some pressure as well. Note that this is done with the left hand. The right hand should squeeze the reservoir bag. Assess each ventilation by watching chest movement. In-tidal carbon dioxide monitors are great, but occasionally go into automatic calibration mode for 5 to 8 seconds. In addition to seeing chest movement, you should feel the bag reinflate during expiration. If mask ventilation is ineffective, sequentially use the following steps. First, reposition the mask in hand placement. If this proves ineffective, insert an oral airway. If necessary, ask someone to operate the bag while you secure the airway with both hands. You likely learned to insert the oral airway upside down and then rotate it during advancement. While essential for patients with intact reflexes, the method is not essential in an anesthetized patient. The rotation method risks bruising or lacerating the palate. After inducing anesthesia, insert the oral airway with a tongue blade. Do not rotate the airway. Rather, with the tongue depressed and pulled forward, drop the airway into position. Few things are worse than squeezing the bag and realizing that nothing went to the patient. Assuming that you have a good mask seal, look to the APL valve. By venting gas from the circuit, the adjustable pressure limiting valve keeps pressure at a safe level. During pre-oxygenation, it's essential that the valve be at 0. However, during mask ventilation, it generally needs to be between 10 and 20 centimeters of water. So where is this important valve? Look for it near the bellows, right next to the switch that turns on the ventilator. Looking from the top, we can say that this valve is set at minimum, or near 0 pressure. Turning the valve clockwise would increase the pressure to 20, 30, or up to 70 centimeters of water pressure. Unless your anesthetist verbally approves, do not set the valve above 20. For several reasons, including that the mask seal is rarely perfect, set an initial oxygen flow somewhere around 10 liters per minute. An anesthesia team member should set this for you. However, double check by looking at the green valve and flow meter. Oxygen will always be the rightmost flow meter on a gas machine. It's essential that you ventilate most patients with one hand. A minority of anesthesiologists and anesthetists realize that you will never use this technique in the field. Most will question your skill if you ventilate a perfect airway using two hands. However, impress them using one hand and they will give you more freedom during intubation. It's also essential that you recognize ineffective ventilations. Given your pre-hospital experience, you have the tools. Verbalize what you see and rely on your already strong assessment skills. You can pass evaluations without understanding the APL valve and oxygen flow meter. However, if you know how to use them, the CRNA will identify you as someone worth going the extra mile for.